Uh, okay, Assalamu alaikum or Masa al khair. I hope everyone here is doing well. Well, first of all, hi, I'm Raffi. For those of you who we've never met, I'm a medical intern, and then I've given this crash course before in a different format. So there's a two-part crash course where I basically cover all of the lectures. The whole point of this crash course is we're not going to go through all of the lectures. This isn't a 6-hour crash course. The point of this is to learn by practicing and then mentioning high yield points of the 4 lectures you guys have assigned, so it's adjusted in the curriculum. Of course, feel free to reach out to me whenever, whether it's by WhatsApp or email, but I don't check my email, so WhatsApp's usually better. And let's get started. So you're probably here. Some of you guys said that you guys don't like ECGs, and that's fine. But this is where you feel right now. Inshallah, this is where we're going to be. Play it. And yeah, his smile's animated. Forgot. Okay, the animations are done. Play it. Ignore these objectives. I forgot to change the table of contents. Forget about these. You have 4 topics: introduction, arrhythmias, ischemic changes, so myocardial infarction, and then enlargement. طيب. Uh, where's the pen? Yeah, let me just get rid of the pen. Okay, so let's start. I always like to start off with a question. Lead 1 and AVF are negative. What is the axis? So remember, we said we're going to stick with the chats. So what do you guys think the axis is? And yeah, let's see what you guys say. Okay, so someone said an option, which I won't say. Another person said the same option. Another person said the same option. Okay, great. So this is a pretty easy concept. So the answer is extreme. How did we get to this conclusion? We'll show you guys in a bit. What are the most important things you need to know from the introduction lecture? First of all, the leads, where we place them and what they actually mean. Then we look at the ECG paper itself. EKG, ECG are the same thing. It's just Americans call it EKG, and then everyone else calls it ECG, and like voltage and time. And then we will talk about the waves, interval lengths, what they mean, how do we analyze, and then how do we determine the axis. Okay, so here, this is a picture showing you the wave of depolarization. So one of the very difficult things that people don't realize about ECGs, and it's not really difficult, it's just no one takes the time to realize this, is the way ECGs work is you have a person, right? And then you place pads on a person. Okay. So let's say this is the person's, and this is the person, and you put a pad on this person. Okay. And this pad is connected and it provides an electrical signal. Basically, what this pad represents it's going to pick up on the electrical activity of the heart. طيب. Electricity can be negative or it could be positive. طيب. And this kind of correlates to the way that the heart moves. So when the portion of the heart gets closer to the lead, it's going to pick up a stronger electric signal, whether it be positive or negative. But usually it's going to be more of a positive signal if we're just taking like the basis of electricity. Vice versa, if it's further away, it's going to be weaker and it's more likely to be a negative force. And this is just showing you how the wave of depolarization works. Not too important, but I only left this for you guys to understand. Heart gets closer, positive. Heart goes away, negative. طيب. Monkey see, monkey do. Okay, here is another very important slide, which is basically how these leads work. So we have 3 types of leads. We have limb leads, augmented leads, and precordial leads. So limb leads are very simple. It straight up just means we put them on, they're related to the limb. So we have a limb from the leg, from the leg over here. This is not your leg, this is your right arm, and your left arm, right? So right arm to left arm is lead 1. Left arm, right arm to leg is lead 2, and then left arm to leg is lead 3. Now, this was definitely important for you to remember for first year, but as a third year, this isn't as big of a concept to know what these directions mean. Even this augmented stuff, it's not too important. But the precordium is, like understanding where the leads go on the precordium kind of is important. It's probably the most important thing in terms of lead placement. So precordial refers to precordium. So this area where your heart is on your chest, or where it represents your heart, this area where your heart sits, this line is called the precordium. And it has 6 leads: 1, 2, 3, 4, 5, and 6. And then, for those nerds, there's 7, there's 8, there's 9, but we'll talk about them way later. And the idea is, so you have V1 on the right side of the sternum, 2 is on the left side, 4 is next to the apex of the heart. 5 is at the anterior axillary line, and 6 is at the mid-axillary line. So V4 would be mid-clavicular line. And then V3 is just somewhere between them. Like we literally define V3 by V2 and V4 for some reason. It's kind of like a middle child. And we also have this. This is very important because this relates to blood vessels. So the different leads, for example, when you're like looking at an ECG, and we'll pull up an ECG chart and go back to this, you're going to see different leads like 1, 2, 3, AVL, AVF, and then the different Vs. So each of them represents a different part of the heart. So 1 AVL, V5, and V6 will refer to the lateral part of the heart. 2, 3, AVF will refer to the inferior surface or the bottom of the heart. And then V1, 2, 3, and 4, they represent the anteroseptal area of the heart. And then we'll have, there's pictures later, which we'll cover. This is very important for what topic? Vascular. It's very important to know what these leads represent because they represent different blood vessels. And then it's also important to know for atrial enlargement and ventricular hypertrophy, but we'll get to that later. What else is important? This right here. Where did I draw that? That was not supposed to be drawn. Hold up. Awesome. Okay, we got rid of that. Okay, let me think the laser pointer might be useful for now. Anyways, so we have this right here, the PQRST, and then for those of you who will ask about the U, we'll get to that later. But how does this paper work? So the ECG is a graph, and you know the graph, it's an XY graph for those of you who like math. So we have an X-axis, which is the horizontal, and the Y-axis, which is vertical. So how do we, what does the horizontal and what does the vertical represent? The horizontal or the X-axis represents time, and the Y-axis or the vertical line is going to represent voltage, right? So in terms of each box is 1 millimeter by 1 millimeter. Okay, so this is 1 millimeter, and this is 1 millimeter, and this is 1 millimeter, and this is 1 millimeter. Okay, so let's start off with time because it's very important for you guys to know the time. 1 millimeter or one small box or square represents 0.04 seconds. 0.04 seconds. That means 2 small boxes would represent 0.08 seconds, 3 would represent 0.12 seconds, 4 would represent 0.16 seconds, and then five small boxes would represent 0.2 seconds. Okay, so 5 small boxes or 5 small squares will make one big square. So this big square we said is 5 small boxes. 5 times 0.4 is 0.2. So this is 1/5 of a second. So how do we get what do we know a full second would look like? 5 big boxes, because it's 5/5 of a second, which would be 1 second. So this, and then over here, that would be 1 second. Just to show you how much can happen in 1 second, and it really shows you how fast the heart actually is. Okay, the voltage isn't too important for you guys to remember. Like this is all 1 millivolt. Like 2 big boxes is 1 millivolt. But if you want to remember, if something you can remember, go for it. Usually when we're describing abnormalities and we're looking at the y-axis, we're usually going to just stick with millimeters. Like when we talk about ventricular hypertrophy and atrial enlargement, we're usually just going to stick with millimeters. But seconds, it's very important for you to know. Why? Some pathologies, you can actually understand that there's a problem with the horizontal axis by the time. So it's very important to remember. And they commonly use time. Like for example, the QRS, so the QRS, this is supposed to be 3 small boxes at maximum. So 0.12 seconds. So if it's any larger than that, problem. Or for example, the QT is supposed to be anywhere from 0.36, I believe, to 0.44. Again, this stuff we'll see later on, inshallah. I have a slide that covers all the times that you need to know. So yeah, anything that doesn't do that is a problem. This U wave, do not remember this right now. This represents a disease called hypokalemia. So when potassium is low, and it represents an abnormality of repolarization. This we'll talk about the polarization, repolarization. I believe it's this slide. Yeah, nice. This panel. Okay, so starting off with the PR segment. The PR segment, this represents شو اسمه the conduction of electric signals in the AV node and the bundle of His. So this should be 0.12 to 0.2 seconds. So 3 to 5 small boxes, or 3 small boxes to 1 big box. QRS represents ventricular depolarization. That should be 1.5 to 3 seconds. 0.06 to 1.5 to 3 small boxes, so 0.06 to 0.12 seconds. بعدين the QT interval is 0.36 to 0.44 seconds, and it represents the ventricular depolarization and repolarization. So this should be anywhere from 9 to 11 small boxes. And just going back to showing you, so this right here, so PR, we said this is where it's being conducted through the AV node and the bundle of His. QRS represents the ventricular depolarization. Right, then the Q with T, this represents the ventricular D and repolarization. طيب. Now you're probably wondering, like, what about the atria? What about all this? What about all this? Okay. If there's anything else that might be important, the P wave only exists because of the sinoatrial node. So the sinoatrial node will send out a signal, and this causes the P wave to form in the first place. Specific details other than that, you don't need to know. And because of this, in the PR, the atrial depolarization and repolarization technically happens, but the repolarization is buried in the QRS. Again, nitpicky details, not important for your exam. Okay, now how do I want you guys to look at the PQRST? This is my way. This literally, monkey see, monkey do, any bare minimum. If you're gonna know one thing to interpret any ECG, this might actually save your life. So the PR represents the atria. The QRS represents the ventricle, and the ST represents the whole heart. For example, sometimes we have a disease called atrial tachycardia. What happens is that there's an abnormal focus in the atria. As a result, the P wave is abnormal. So the P wave, you see, it's that's nice, it's upright. I know this is a drawing, but it's nice and upright. Let's say in atrial tachycardia, it goes upside down. There you go. You know the problem is in the atria. There's an ectopic atrial focus. Let's say the QRS, what could go wrong? So let's say the QRS is really tall, you know? If it's really tall, this is a sign of ventricular hypertrophy. Great. Ventricular hypertrophy. I know it relates to the ventricle. What if it's wide? Then it represents ventricular tachycardia or ventricular fibrillation. So by looking at the QRS, if there's something wrong with it, if it looks wrong, I'm looking at something with the ventricles. But an ST represents the whole heart. So for example, ST segment MI or ST depression or non-ST, you know, you're looking at the ST segment, or diseases like pericarditis where you have all of the ST segments elevated and PR depressed, but don't worry about that for now. But that's the thing. You can literally look at these 3 parts and you understand what's going on. So that's why in the systematic analysis, you do want to include looking at the P, R, QRS, and ST. Okay. Now, here is how we count the heart rate. So remember, I told you guys in the one small box is 0.04 seconds. And five small boxes will make one big box, which is 0.2 seconds. So in order to get 1 second, we need 5 big boxes. طيب. So you can do this with large or small squares, but you have these different formulas over here just to make it easier. But for example, let's say you saw QRS to QRS. So when we're counting the heart rate, by the way, you look at the QRS, the distance between QRS1 and QRS2. And basically you see how many boxes are between. طيب. So for example, if you saw 5 big boxes between QRS to QRS and it's regular, this means there is 1 QRS every second. This means that the heart rate is 60. But if you don't like keeping your life simple and happy, do the math. طيب. What if it's irregular? Like for example, let's say, you know, it's irregular. The QRS complexes, you know, you have 1 after 5 small boxes and 1 after 5 large boxes because, you know, you have arrhythmias which have irregular rhythms. You look at the rhythm strip. The rhythm strip is 10 seconds. So that's a guarantee. And after you look at the rhythm strip, you basically see how many QRSs are in that rhythm strip, and then you multiply that by 6. Is it the most accurate thing? Not really, but it's accurate enough for us, as a physician, to make an assessment. طيب. Again, don't use this for the regular. For the regular, do the math or look at this graph. Okay, axis determination. I'm going to keep it very simple. I have a very nice diagram which will explain all this. Basically, look at lead 1 and AVF. one is positive, if they're both positive, so everything's good, this is normal. If lead 1 is positive and lead AVF is negative, that means they're looking away from each other. And if you look in ECG, one is like lead 1 is over here and AVF is over here. So they're looking away from each other. So they left each other. So left axis deviation. But then right axis, so lead 1 is negative and lead AVF is positive. So they're looking at each other because they're right for each other. وبعدين if they're both negative, and I'll explain to you guys what I mean by positive and negative. If they're both negative, they're both looking down. This is extreme because they should not be sad. They shouldn't, both be down. طيب what do I mean by يعني قاعد اتفلسف الحين شوي. what's positive, what's negative بس عشان ما اتفلسف عليكم. QRS looks like this, positive. QRS looks like this, negative. That's simple. So if they're both like this would be both of them positive, so normal axis. In this case, let's say this is 1 and this is AVF. Can someone tell me what the axis is? In the chat, of course. Don't unmute your mic. We got a chat. Okay, someone said an answer, which is correct, actually. So good job. So it's left axis deviation. So 1, AVF, they're looking away from each other because they left each other. Good job. But it's very simple. This is just to show you how it looks like and how did they decide in Wallah this axis is positive or negative. Again, it's a little bit detailed, not really worth going into time, but it's this would explain it. If you guys really want me to, it's not too important. As long as you understand this, you're fine. But if you want me to explain it, I'm more than happy to. And this would basically be the end of the intro lecture. Okay, do you need to look at lead 2? Yes and no. So lead 2 will help you when you're thinking of left axis deviation. طيب. So that's the only time where you really need to look at lead 2, but generally speaking, you don't, other than looking at lead 2. Okay, you know what? I think I should go into the positive negative stuff. Okay, let me draw a circle for you guys, just to keep it simple. I'll draw a circle. Okay. So normally, and I'm going to draw this. So basically we have this over here. طيب. Lead 1, when we say in the lead 1 is positive, it takes up this part of the pie. And when we say lead AVF is positive, it takes up this part of the pie. And then when we say lead 2 is positive, it takes up this part of the pie. Okay? So in this direction, it's positive. This is how they're normally supposed to be. If they did the same thing, but for example, you had a lead go like this, and a lead go like this, and another lead that goes like this, so they don't occupy this like 30 to 90, negative 30 to positive 90 space, that means they're all negative. So this would be an example of extreme axis. So this is to understand what it means by positive and negative on the pie. So let's start off with lead. Let's say we're trying to think of a left axis deviation. In left axis deviation, we said inna lead 1 is positive and lead AVF is negative. Lead 1 is positive means this. And AVF negative means this. Now, why do we look at lead 2? If you guys notice, there's this thing right here. This 30-degree portion right over here. And the thing is, this could technically still be normal axis because this negative 30 degrees is still within the negative 30 to positive 90 range. Okay. So how do you go about this? Let me change the color. If lead 2 is positive, then you're looking at a normal axis. Why? Because all three of them, 1, 2, and AVF, they all meet in this negative 30 to 90 range at some point. But if lead 2 was negative, then this is a true left axis deviation. Why? Because they don't meet between negative to 30 to 90. So this negative 30 to 90 is very important. Remember this, right here till here. If all three of them meet, oops, I drew a little bit too much, Manish. If all three of them meet in this green space, at some points, you're good. Otherwise, you're not. Maybe, I don't know. That's the whole pi stuff. It's a little bit complicated, but just imagine, يعني positive, negative, if you understand that. But then you know, and this is for lead one, and this is for lead AVF. So positive means it's supposed to be like this. And then we only look at lead two for left axis deviation. That's why there's the asterisks around it. So yeah, again, because this lead, they all meet in this area, that means we're fine. Okay, how do I, like Raffi, solve EKG questions? Okay, there's a systematic way that you should look at. And then there's my way for just exams. So how should you look at it systematically? You look at the rates, rhythm, you look at the PR segment, QRS, ST, and then you determine the axis. So you want to look for where is the abnormality. How do I look at it? I take a general glance at the question and I try to see, is there something that looks off? So let's say I'm looking at, for example, I'm looking at the P waves and they start to look abnormal. Okay, let me look at a certain lead. So V1 and 2 and then lead 2. And then, or if I think it's something wrong with the ventricles, I look at precordials. If I think it's MI, I'm looking for the shark attacks. If I'm looking for a tachyarrhythmia, then again, you could use this as you like, and then the heart rate might try to throw you off. Like it might look like it's normal. So just look for anything that looks abnormal, and then just point that out. That's my usual way with questions. Okay, let me show you guys how you should interpret this. So the first thing you need to do, and in the hospital, obviously you identify the patient. This is their EKG. It was ordered for whatever reason, and then you start. So you look and you try to determine the rates. The machine will mostly do that for you. Because we said we determined the rate. So you look at 1, 2, 3, 4, 5. So there's 5. Wait, you go. 1, 2, 3. Sorry, 4 big boxes. Managed, not 5 big boxes. So there's 4 big boxes between the QRSs, and they look regular. So rate and rhythm. So 4 big boxes means 75 beats per minute. And I know that it looks regular. When I look at the P, so I'm looking at the P here. Okay, P, PR, QRS, ST, all looks normal, right? And I'm looking at them, it's all normal. Alhamdulillah, great. ما في إلا العافية. This is a normal ECG. So that's how you would do it. Okay. This one was supposed to be deleted because not related to you guys. But that's it in terms of the basics of ECG. So is there anything you guys didn't understand or would like me to re-explain? Everything is great. Clear. Alhamdulillah. Okay, great. At any point, feel free to stop me if there's something you don't understand. Otherwise, we'll go into the questions. So this, skip that. Okay, what leads represents the inferior cardiac surface? Who wants to answer this in the chat? Okay, so someone said an answer. Another person said an answer. Another person said an answer. You guys are all saying this. 4 people have said the answer, and it's correct. Absolutely. It's choice D. 2, 3, and AVF. طيب. What if I was going to ask about V1, 2, 3, and 4? What would that be? The anterior. Yeah, this would be the anterior and septal region. So the septal, anterior, good. What about 1 AVL, V5, and V6? Because I just put them as 2 different options, but they represent the same surface. Lateral. أحسنتو. Good job. You guys are geniuses. Like, here's a practice ECG. Yeah, so that's it for the basics. So we're done. Now we're going to go into arrhythmias. So this is an example of an arrhythmia. Now, you probably may or may not know what arrhythmia this is. You could do this systematically, or you could do this the Raffi monkey see monkey do way. Okay. طيب. You guys are correct. They said the arrhythmia, it is correct. But what told you that it was this arrhythmia? How did you know? Exactly. You looked at the QRS. Monkey sees, monkey does. The monkey saw the QRS. The monkey knows that there's a problem with the ventricles because the QRS looked weird. So even if you said, for example, that there was a problem with the ventricles, if that's all you knew, you are on the right track, 100%. طيب. The QRS, here it's wide. And then I'll explain why we would call this ventricular tachycardia in the lecture, because you guys are absolutely correct. This is ventricular tachycardia. Wow, 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 wow. YQRS, rapid rate, no clear P waves. Wow, mashallah, you guys are very smart. Okay, so what's the important information when it comes to arrhythmias? So the lecture that you guys have for arrhythmias classifies arrhythmias by location, which I think is a very convenient way to do it. But I also have my own algorithms, which I like doing, and I use them a lot. And then the other thing to understand is when we're classifying arrhythmias by location, each location has its own speed. And we'll talk about mechanisms management. Okay, mechanisms. This is what, yani, just read this. Yani, take a screenshot if you want. This is going to be on YouTube, so just go through it if you'd like. And then treatments, again, go through it if you like. ACLS is never a wrong answer, by the way, for any tachycardia or bradycardia question, because it is an advanced cardiovascular space. Same thing here, again, just read these. I'm not too curious. Here, for me, these are my algorithms. I use these for third year. I use these for fifth year. I use these for step one. Walhamdulillah, alhamdulillah, بكل مرحلة بحياتي, I found a benefit from them. So inshallah, and if you ever need these algorithms and you do end up using them or you use anything, inshallah, you do find benefit from it, whether it's your FESL exams or your board exams, inshallah. First of all, how do we define a tachyarrhythmia? طيب. A tachyarrhythmia, tachy means high. So when arrhythmia, abnormal rhythm. So it's a high abnormal rhythm, meaning high heart rate, abnormal rhythm. The normal heart rate for an adult is 60 to 100. طيب. So we mean the heart rate has to be over 100, meaning the RR interval, which يا طوال العمر, this right here is the RR interval. So RR, the difference between two QRSs. This needs to be three big boxes or less. طيب. So this is box one, box two, box three. If it's smaller than this is a tachyarrhythmia. طيب. Let's go back. And then there is a kind of a way to understand this, but we'll get into that. So you look for the RR intervals. And let's say you don't even look at the RR intervals, you're looking at a tachyarrhythmia, and you just know it's something wrong. You look at the QRS. Is it narrow or is it wide? Or does it even exist? If it's narrow, is it regular or irregular? If it's regular, look for the P wave. If there's a P wave and the axis is normal, this is sinus tachycardia. If there's an abnormal axis, it's atrial tachycardia. If there is no P wave, look for the sawtooth pattern. If you do see a sawtooth pattern, it's flutter. Otherwise, you're looking at SVT. طيب. بعدين, irregular. Let's say it's a narrow QRS, but it's irregular. Look for P waves. If there are P waves, this is multifocal atrial tachycardia. This is related to COPD. And then if you don't see a P wave, that's AFib. Irregular. Wait, no, go back. Okay, let's say that's for narrow QRS. What about wide QRS? There's three things. If you just see this, for example, and it's just wide QRS, but it's regular, this is ventricular tachycardia. There's no P wave. It's just wide QRS. If you see Arctic monkeys, and for those of you who don't know Arctic monkeys, honestly, just look it up. But if you see the Arctic monkeys ECG, this is torsades de poing. This is basically, it's like two, it's a French word describing like two ribbons and acrobatics, something like that. But basically, it looks like Arctic monkey, so I think it's easier to understand. And this is a complication of ventricular tachycardia, and it's impending VFib. And then something called Wolff-Parkinson-White. So this is my mnemonic for it, WPW, Wolff-Parkinson-White. So there's an abnormality with the wave, the PR is short, and the QRS is wide. Technically, Wolff-Parkinson-White is a type of SVT, but the QRS is wide. So again, you're not looking to see, is this a type of SVT? You're looking at the ECG itself. If there's no real QRS, this is ventricular fibrillation. And if it's just boom, that's asystole. Okay, what about bradycardia? So we said tachycardia, the RR interval needs to be three big boxes. طيب. And we said the normal heart rate is 60 to 100. So tachyarrhythmias need to have a heart rate of over 100. البراديارrhythmias لازم يكون عندهم a heart rate of under 60. طيب. Now we could look at three different areas: the SA node, the AV node, and the bundle branches. Now the bundle branches are not included in your lecture. X cancel. طيب. Also, alhamdulillah, because they're very weird looking. But you will need to know that at fifth year, fam. That's for fifth year. Right, then we have the sinoatrial node and the AV node. طيب. The sinoatrial node, let's say you're looking at it, it's regular, but it's just كده, it's slow. طيب. This is sinus bradycardia. If it's normal heart rate, but then all of a sudden it just pauses and then goes back to normal, usually the patient isn't sick, they're completely normal. This is called sinus pause or sinus arrest. Um, and then if, for example, they have tachycardia, it pauses and then it becomes bradycardia. This is called tachybrady syndrome. And then if the patient is actually complaining of chest pain or palpitations or any symptoms of arrhythmia, then we call this sick sinus syndrome. All right. By then, an AV block, this is pretty important. This is super high yield. Like, you're going to see so many of these questions. You look at the PR interval. طيب. The PR interval is going to tell you, for example, if it's just a PR delay, great. This is first degree block. If it's second degree block, we have two things. We have Mobitz 1 and Mobitz 2. Mobitz 1 means the PR is getting wider and wider and wider, and then there's a beat drop. This is fine. Mobitz 2 means the PR is fine or it's delayed, but it's the same, and then boom, just beat drops. That one's bad. That one's dangerous. That one's as, if not almost as dangerous as third degree, where the PR and the QRS don't even relate. Like you have P waves just kind of bouncing, and then you have a QRS kind of for some reason. It's like lost and loster. That's what I like to think of them as. But how do we know, for example, let's try use the monkey method, How do we know where everything is? The P wave, like we said, is going to tell us where the problem is. So if there is a problem with the P wave, that means it's related to there's something wrong around the atria, right? So for example, the presence of a P wave, normal, just sinus tachycardia. If it's abnormal, great. There's something wrong. The P wave is going to look abnormal, and it's going to tell us there's a problem with the atria. What is it? There's an abnormal focus. Right then, for example, we're not going to see a P wave here in these two. So we know that there's a problem with the sinoatrial node or the atria, right? And then with the ventricles, because the QRS is wide, this is going to tell us, okay, great, the problem is in the ventricles, whatever it may be. And then if we look at the sinoatrial node, again, because it's essentially just sinus. So when we say the word sinus, we mean like the normal heart rate. So it's just going to look completely normal, but the sinoatrial node's acting up. AV block, that you see, we have a problem with the PR. The PR is the problem. So it tells us, okay, great, the problem is in the sinus, anywhere from the sinus node to the atria to the AV node. So this is kind of the monkey see, monkey do thing I was talking about. And the bundle branches, although they're not with you guys, they would have abnormalities with the QRS. But you would know it's a problem with the bundle branches, which are in the ventricles. Okay, how does this lecture want you to remember arrhythmias? Basically, you need to know two things. First of all, the location, and the second thing is the terms that we can use. So if the QRS is narrow, that means it's not in the ventricles. So wide QRS means ventricles. Narrow QRS, it could be sinus, it could be atrial, or it could be junctional. Sinus means there is nothing wrong with it morphologically. It's going to look like the normal PQRST. Atrial means there might be a problem with the P wave. And junctional means that there's no P wave, but it's regular. Atrial is usually irregular. Okay, so this is how you understand it with location most of the time. In terms of the terms you should use, premature. So if you say like a premature contraction, this means you have normal sinus rhythm and just one random beat. طيب. Right, in rhythm, let's say we say sinus rhythm or atrial rhythm or ventricular rhythm. Basically, each part of the heart has its own rate at which it conducts. If you have a problem with the sinoatrial node, and one of the properties of automaticity of the heart is, and when the sinoatrial is, and then if one part falls down, the other will kick back up. ف يعني that's the thing with the heart. For each part afterwards would have its own rate. So ventricular rhythm, atrial rhythm, each one has its own rate. When it's at that rate, we call that rhythm. And we'll understand this a little bit more. Tachycardia is when the rate is accelerated. So for example, if it's sinus tachycardia, this means it means high heart rate relative to the sinus. طيب. Fibrillation means these random kind of waves. And I put like M's and W's, but once we see a slide of atrial fibrillation, you'll understand what I mean. Flutter, this should be the opposite, honestly, where it's like this, and it literally just looks like flutters or sawty, and then asystole. Oh. Yep. Okay, so yeah, that's all the things I have to explain directly. And then we have some practice. So is there anything from these two that you guys don't understand, or these three slides that is confusing, or you guys don't understand, or you'd like me to re-explain?
Yeah, the location, please.
Sure. Okay. So do you mean the location for this slide or the previous slides?
This one.
Okay. حلو. So location is very simple. You look at the QRS. If it's wide, great. You know you're at the ventricles. The problem, whatever you're looking at is related to the ventricles. If it's not, okay, narrow QRS means three places. The sinus node, the atria or AV node, and then the junction, which is basically like the atrioventricular junction. Like, and this is usually where the bundle of His is. So if it's a problem with the sinus node, or if the sinus is responsible for this rhythm, it's going to look completely normal. It's just, for example, the rate might be different. Or like we said, you might see tachybrady, or it might just pause, but morphologically, it looks fine. With the atria or the AV node, basically what we're saying here is there's usually no P wave. Like there's rarely ever actually a P wave. ف or there's something wrong with the P wave. Um, and usually it's irregular. The only exception to this is atrial tachycardia and atrial flutter. And atrial flutter, you identify it through the sawtooth. But it's an abnormal P wave. That's good enough. Junctional does not have a P wave and is regular. طيب. So let's say you're looking at this. Let's go back to this, for example. Let's say this P wave right here didn't exist. And these two QRS complexes, let's say it was كده, there was a QRS right here. طيب. So because there's no P wave, I know this is junctional. And let's say they're here. If this is high for the junction, this would be a tachycardia. Does the location aspect make sense to you now?
Yes.
Alhamdulillah. The question you said, well, when Parkinson usually wide, narrow unless it's antidromic. Okay, that's a good point. So with Wolf Parkinson White, uh, so the whole antidromic prodromic, I know the slide you're referring to. Basically the idea with Wolf Parkinson White or with the SVTs is Wolf Parkinson White is an example of an antidromic SVT. Uh, now, yeah, that's the main point with it. And then Wolf Parkinson White, because SVTs they're related to abnormal like the whole AV-NRT stuff. So you have prodromic and antidromic. Wolf Parkinson White technically falls under the antidromic category. Now, if something's different and if something different is written, please let me know. عشان I'll double check it إن شاء الله. لأن again ما أبغى أتفلسف عليكم هذه الناحية. بس yeah, perfect. Okay, great. So let's resume. Now we have a practice here. So can anyone tell me what this is? Okay, now they're thinking. All right, they're cooking. All right, so it's a little bit confusing. So how about we'll come back to this. We'll learn through the other arrhythmias because they'll have everything, but we'll come back to this one. طيب. Um, okay. So let's come back to these. Let's go through these first and then come back to those. Okay. So here, what do you guys think this is? So let's break it down. So systematically, first thing you want to do is look at the rate and the rhythm. So the rate you can see here is 1, 2, 3, around 4 big boxes. So this is normal heart rate. The rhythm is regular. The P wave it looks normal. The QRS is normal. And then the ST segment is also normal. And the axis, well, we can't determine it, but we'll assume it's normal. So what do you guys think this is? This is normal. Exactly. This is normal sinus rhythm. Okay. What about this one over here? So let's do the same thing. Rates. You guys tell me how many boxes there are here. The rhythm. Okay, so someone said the correct answer, so look at the rhythm as well. The rhythm is regular. Um, rate is regular. Or rate is not regular. Rate is actually pretty slow, but everything else is fine. So again, sinus ready. So remember, I said if it's a problem with the sinus node, you'll see in the morphology, it's completely normal, but it's just a problem with the rates, not the rhythm. Here we have another issue. So you look at the rates, look at the rhythm. Okay. Uh, yep. So this is sinus pause or sinus arrest. So you see before this, you have normal sinus rhythm over here. And then it just takes a break. I don't know why. It takes a break. And then just comes back normal. So good job. This is sinus arrest. What about these? This one might be a little bit difficult, but I believe in you guys. And remember, be systematic. Okay, so someone said the correct answer. Good guess, but no, but someone said the correct answer. Okay, so this is tachybrady. How did we get to this? Over here, you have period of tachycardia and then periods of bradycardia. طيب. Now, if the patient is not complaining, this is what we would call tachybrady syndrome. But if the patient does have symptoms, we would call this sick sinus syndrome. All right, let's look at this one over here. So look, first of all, the rhythm looks irregular. So can someone tell me what the heart rate is here and how you got to it? Like that's my first question to you guys. Before tell me what the arrhythmia is, tell me how you would do the heart rate for this. All right. Yeah, so you count how many, so this is 10 seconds. You see how many QRS complexes there are. So here we have 1, 2, 3, 4, 5, 6, 7, and 8. So this is 10 seconds. So we have around 80 beats per minute. Here it says 88. Why? Because they actually went and did the full 60-second heart rate, and there's a machine that calculates this. But yeah, pretty much. Or sorry, no, did I say 8 by 10? I meant 8 by 6. I'm sorry. So again, it's going, and you're gonna get a different number than here, but you can identify and it's irregular. Yeah, so this would technically be 48. Is this actually 48 beats per minute? No. But again, for some reason, we're supposed to do this. We know it's abnormal. There are other ways to calculate this. It's a little bit weird, and you're never going to be asked to calculate it, but this is just for your sake. But you can tell that this is something irregular. The question is what? Okay, so that's fine. Premature atrial contraction. How did we get to this conclusion? So they're kind of playing a trick on you here. This is actually normal sinus. Technically normal sinus. But what went wrong? If you look at this QRS right over here, this is the only one that looks wrong. Really, this one is normal. So you have a normal P, QRS, ST. P, QRS, ST. right? And then you just have this random P that goes upside down for some reason. And it just messes up the whole thing, which is why we got 48 aslan. In reality, this is around anywhere from 75 to around, I would say 90. Because it's all four big boxes except for this one for another reason. Because again, premature atrial contraction right over there. Okay. So if you get, let's say you're looking at normal sinus rhythm. So this right here, you're looking at a normal sinus rhythm. You know, everything's fine. All of a sudden, you're looking, just goes the other way. Why? This thing that goes the other way. The thing that follows it, bad, that's the thing, is normal. So this interruption in normal sinus rhythm is called a premature contraction. And we look at the morphology of this contraction to decide where it is any bit and location. So we said there's an abnormal P wave, as you guys can see. That abnormal P wave tells me, and that this is an atrial problem. So that's why we said it's a premature atrial contraction. Let's say we had an abnormality in the QRS and there wasn't a P wave. That would be junctional. Or let's say it made the QRS wide. That would be ventricular. But this random interruption in normal sinus rhythm, this is a premature contraction. Based on the morphology, we give it a name. Does that make sense to you guys? Okay, that's fine. Let's go back. Let me try explain this in another way. Let me clear these. Maybe this will be a little bit clearer. I understand this part's pretty confusing, to be honest. Okay. So let's go back. طيب. No, I don't want the eraser. Okay, let's go back. طيب. This QRS, just this one right here. طيب, with the line. Or no, not with the line. The line's, I don't like this line. Okay, let's go back. This QRS right here. Is this normal? Yes or no?
Yes.
Yes, it's normal. Okay, this QRS over here is normal. This QRS after it is also normal. طيب. So these two QRSs, until now, before this contraction, we have normal sinus rhythm. Let's assume the entire thing before this is like this. This is normal sinus rhythm. Yes or no?
Yes.
Yes, exactly. Then you get this interruption over here. You see, the P wave is going down. It's a negative P wave. And we said if there's a problem with the P wave, look at the atria. طيب. So this entire contraction is abnormal. It decides to take a little bit break. The heart decides to take a small break. And then all of a sudden, boom, PR back to normal. This QRS, is it normal?
Yes.
Yes, this QRS is normal. طيب. The one that comes after it is normal. The one that comes after it, still normal, right? And then you get this abnormality. So as you guys see, it just happens kida, randomly. This random abnormality means it's a premature contraction because besides these abnormalities, we have normal sinus rhythm. If the entire rhythm strip was irregular, طيب, then you're looking at a completely different issue, right? سواء كانت AFib, سواء كانت SVT or whatever, right? But you're just getting these random premature contractions that, this is still sinus rhythm. If you were to take these out, this would be sinus rhythm, right? But you have these premature contractions. So these interruptions in a normal sinus rhythm, this is a premature contraction. To decide what kind of premature contraction it is, we look at the morphology of the QRS. And here we see that the only abnormality is the inverted P wave. So we say it's atrial. Does that make more sense now?
Yes.
So half sinus rhythm is random return. Yeah, pretty much. The sinus rhythm, as long as it's sinus rhythm, besides these points, these random points would just be irregular contractions. And that's why it makes it look irregular. That's why you guys got a heart rate of 48. And for some reason, my math was so bad, I got a heart rate of 80. But anyways, the reason why it says 88 here, and the reason why I said don't pay attention to this, was honestly just to throw you guys off. So I apologize. But yeah, the points of this, زبدة الموضوع, and if you have normal sinus rhythm, But then you look at the PQRST, you get one random abnormal one. You play it, but it resumes in sinus rhythm. Even if you get another one later, as long as you're resuming to sinus rhythm, this means this contraction, this PQRST, which represents a whole contraction, this is abnormal. So we call it premature. And then you look at the morphology, you look at how it looks to decide where it is. So this is atrium. So I hope that's clear. Okay, let's try this one over here. What do you guys think? Okay, maybe you don't know the name of the arrhythmia, but can you tell me where the problem is based on what you're looking at? Like, where is the problem? It looks like no P wave, atrium. Yeah, so the P wave is just inverted. It's a negative P wave, but otherwise, everything's fine. The QRS is under three small squares. The rhythm is regular. The rate is regular. So the rate's actually, no, it's high, right? This is around, I would say, it's over 100. I don't want to do any more math, but it's around, I'd say maybe 120, something like that. And then the P waves are inverted, but otherwise there's something wrong. So this would be atrial tachycardia. Like, so how did we get to this? We said look at the P wave. For the atria, you look at the P wave. If there's an abnormality with the P wave and everything else is fine, this is atrial tachycardia. And that's why, if you were to refer back to this, RR is less than 3, QRS was narrow, and the P wave existed and it was regular, but the axis was abnormal. Oops. The axis was abnormal of this P wave. As a result, we call this atrial tachycardia. And this is what it looks like in big. So had to, for example, uh, if you were to look at these, it's inverted. It's inverted P waves, which is not normal.
When it comes to like the 12 leads, can you go back a little bit? Okay, so for arterial tachycardia, for an example, is it all the same? Like I can look at any lead, or do I have to like look at lead 2 or AVF or V2? You get me?
What do you think?
I genuinely don't know. Like that's the only
Okay,
thing
that's
that
fine.
is.
So the thing is, usually, like as you can see here, they highlighted lead two. The reason is lead two generally tends to look pretty normal. A lot of doctors, when they want to look for these abnormalities, they'll look at lead two. Really, it's a preference thing more than anything. As long as you can identify the abnormality, you're good. Okay, let's go on to the next one. So, calculate the heart rate, look at the rhythm, and try find something abnormal. Okay, so someone said a word I like to hear. Any other guesses, chat? Okay, nice. So, yeah, this is atrial flutter. How did we come to this conclusion? Sometimes it's literally going to be right in your face. You're going to see the sawtooth pattern. If it's right there in your face, لا تتفلسف. Monkey see, monkey do. That's my philosophy with tachycardias and life, honestly. If monkey sees, monkey does. Um, if you see the sawtooth pattern, you are almost always looking at atrial flutter. When would you not be looking at atrial flutter? You don't know what a sawtooth looks like. So yeah, this pattern right here is sawtooth. طيب. Oh, now it can be regular or irregular. Atrial flutter is not strictly regular. So as you guys see, here it can be irregular. So someone who were to see this would see irregular, irregular, and be like, oh, atrial fibrillation. Now, if you were to diagnose this patient as atrial fibrillation and treat them as such, you wouldn't be doing too much harm because the treatment for the most part of atrial fibrillation and flutter is actually quite similar because they both can cause strokes. As long as you prevent that from happening. But the patient themselves, they might be حساس. Like I don't want to have the generic stuff. I want to have the special stuff, which is flooding. So sawtooth, flutter. Cool, cool. Okay. And as you guys see here, yeah, it flutters. And sometimes it may not be prominent. Like if you were to look at AVL, for example, and only AVL or 1 and 3, you'd say, sawtooth? Nah, atrial fibrillation. But if you look at everything else, the majority all says, no, we're sawtooth, we're fluttering. So yeah, atrial flutter. Here's a much cleaner way that we all imagine that the sawtooth looks like. Kind of looks like the upside down of my U's, but yeah. Okay. What about here? What do you guys think this is? Okay, two people have said it. Let's see who else. All right. Yes, this is atrial fibrillation. How did we come to this conclusion? So first of all, this looks irregular. So if we count the rate, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Now, technically, this would be 60, but you're looking at it and you're like, okay, this is irregular. So maybe it's not really 60. It looks like it could be 60, but it's not really 60. And it is not really 60. It's a lot more than that. It's anywhere from 350 to 500. And the reason is it's contracting, but it's not picking up the ECG isn't even picking up on all the contractions because the heart is literally just like fibrillation literally sounds and it sounds like what it means, which is honestly pretty interesting. So as you guys see, it's irregular, and it's irregular, and you're looking at it and you see these, they don't look really like saw teeth. They look like the word fibrillation, or they look like what fibrillation would mean, because that's literally what fibrillation means. ف
Best can I add like my few cents in? So there is no normal T wave, I guess, or like there's like P waves. Is there like problem with P and T waves?
there's a problem with everything. Uh,
Yeah,
the only thing
it's
that's
just the
normal about
cures.
this is the QRS being narrow. That's the literally only normal thing
Mhm.
about atrial fibrillation. Otherwise, it's just completely abnormal.
Okay.
So you guys are correct. This is atrial fibrillation. Now, the thing with atrial fibrillation, you see this one looks a lot faster than this one. So there's something called fast response and slow response, and this is just, is the ventricle responding at a fast or slow rate? Because again, the discharges aren't properly being picked up, and as a result, the contractions aren't proper. So atrial fibrillation is pretty dangerous, funny enough. So yeah, this is actually atrial fibrillation, but it's slow ventricular response, and you can't see the fibrillations themselves, but you can see that it is irregular and irregular. So you still see an irregular pattern, and if you were to zoom in, you would probably see those fibrillations. Okay, what about here? So what do you guys see? Like, don't tell me what the diagnosis is. Tell me what you're seeing. Some are missing P waves. You're right. Some of them are missing P waves. Where? Okay. Is there a missing P wave here? In the fourth QRS. So 1, 2, 3, 4. You mean this QRS? Absolutely. Yes, there is a missing P wave in this QRS. So besides this missing P wave, is this norm? Would you say that everything else is normal? Exactly. Yes. So we said, and don't tell me the area, but this would be considered what? It'd be considered premature. Absolutely. So this is a premature contraction. How did we identify this as a premature contraction? We looked at everything and it was irregular. So we thought, what if this is the only irregularity? What if everything else is normal sinus? So P, QRS, T wave, normal. P, QRS, T, normal. Oh, wait, where's the P? And then it just decides to take a break and causes everything to be irregular. So this is a premature junctional contraction. Remember, premature atrial has an abnormality with the P wave. Junctional is like, why have an abnormal P wave when I could just have no P wave? So that's the logic it uses, and as a result, it doesn't have a P wave. And then let's say it was the same thing, but the QRS was wide. What would we call that? PVC, right? Polyethyl vinyl chloride. Good job. Plastic. Premature ventricular contraction. Okay, so yeah, PJC. This is a this is a PJC, but if it had a wide QRS over here, that would be a PVC. كما الشيخ ياسر قال. Okay, over here, what do you guys see? There's no P waves. You're right. There are no P waves. Is this regular? Yes, it is regular. Is the and the rate? Can someone tell me what the rate is? So QRSs. So it's regular, so you could just use the box method. It's pretty slow, actually. Yeah, it is. And you could think of it as Brady. So let's do the rate. So this is 1, 2, 3, 4, 5, 6, 7. Or I'd say it's maybe 6.5 for, yeah, let's say 6. Honestly, let's say with 6. So the rate of this is actually 50 beats per minute. Played. So 40 to 50. This is actually pretty slow. But we're not going to call it a bradycardia. This is a junctional rhythm. Why? Remember, I told you guys the heart has a property called automaticity. So this property of automaticity means that when something, for example, fails, like let's say the SA node fails, whoever comes after him will take over. In which case, it's the AV node. And if that fails, the bundle of His will take over. And if that fails, the bundle branches will take over. And if that fails, the Purkinje fibers will take over. So in this case, this is kind of an example of what happens when the bundle of His or the AV node take over, because this SA node isn't working. So this is actually the normal rates of the AV node. So we call it junctional rhythm. So remember, junctional is usually regular. There are no P waves, and it's slower than sinus. So junctional rhythm coming from AV, yes, it could be AV or bundle of His, but usually AV. Because remember the AV node and the bundle of His, they're very close in proximity. So they're at the atrioventricular junction. So usually it's the AV node, but sometimes it can be the bundle of His. So yeah, this is the normal rates of the junctional system. And as you can see, there are no P waves. The QRS is normal, the ST is normal, but the P waves just don't exist. Like, what about here? What do you guys think? What do you guys see?
I just have one quick question so that
Sure.
I don't mess them up. So premature junctional rhythm is basically there is no P wave and it's irregular, and junctional rhythm there is only no P wave, right?
Okay. So remember, let's go back to the concept of premature. We said premature, normal sinus, and then there's one or a few parts which are abnormal. So the rhythm is normal, and then you have some sort of abnormality. Like right here in premature junctional contraction, this is the abnormality. We know this abnormality in the background of normal sinus rhythm is a premature contraction. So we know this is a premature contraction. Now we need to describe it. No P wave, normal QRS. This means it's junctional. So premature junctional contraction. Here in junctional rhythm, we said that the junction has normal QRS, no P wave. So what happens here is no P wave, normal QRS. This means this is a junctional problem. And because this is at a heart rate of 40 to 60 beats per minute, we call it junctional rhythm.
Okay.
So let's see this. No, so someone said no P waves. The QRS is not wide here, but there's no P waves. What about the rate? Is it high, low? Is it regular, irregular? Ooh, someone said a very interesting word, JTAG. Okay. So this is technically called accelerated junctional rhythm. So because We'll talk about what when we consider it JTAC in the next one. Yeah, spoiler, but if you see here, it's the same thing. Normal QRS, no P wave, but it's faster than the one before. So it's one, two, or it's one, two, three, four, less than five. So it's around 70, let's say. And as a result, because that's the case, it's over 60, so it's accelerated, but it's not at the threshold, which we consider tachycardia. What about this one? What do you guys think? Now this would be JTAC, yeah. So the reason that this is JTAC is in the threshold in which we call it tachycardia for the junction, طيب, is 100 beats per minute. So from 40 to 60, this is the junctional rhythm. From 60 to 100, this is accelerated. And then over 100, we consider this junctional tachycardia. طيب. And as you guys can see, there's no P wave, the QRS is normal, and the rate is high. It's less than three big boxes. So this is junctional tachycardia. Good job. And what about here? What do you guys think this is? Okay. Yeah, so this is SVT. Play it. So this is supraventricular tachycardia. Basically, the threshold for junctional tachycardia is 100 to 150. Beyond this, when we see this exact morphology, but it's over 150 beats per minute, meaning two big boxes or less, we consider this supraventricular tachycardia. Why? لأنه فلسفي. And yeah, it's about the bundle of His, really. But again, nitpick details, not too important, but it's important to remember the threshold. So 40 to 60, 60 to 100, 100 to 150, 150 to infinity and beyond. And yeah, this is supraventricular tachycardia. Supraventricular tachycardia is a type of AV node reentrant tachycardia, like Wolff-Parkinson-White. Yeah. Okay. Now we're going to look at this. What do you guys see here? Right? T-wave problem, maybe. Someone said PVC. Two people said PVC. Okay. So if you look at this over here, remember, this looks like a normal PQRST. This looks like a normal PQRS. Wait a minute. What is this doing here? There's no P wave. QRS is wide. I know it doesn't show too clearly, but the QRS is wide. So just trust me, bro. And as a result, it's causing everything to be abnormal. So this T wave is going to look abnormal. You did correctly point that out. Takes a break, goes back to normal. So there's normal sinus, except for this point. So if there's an abnormality in the background of normal sinus, this is most likely a premature contraction. And then because of the morphology, because the QRS is wide, this is a premature ventricular contraction. Okay, could be unifocal, multifocal. So yeah, very cool stories. But as you can see, as long as the QRS is wide, as you guys can see over here. So multifocal just means it's one focus, and multifocal means it's multiple foci. So like up, down, whatever. And yeah, this is kind of showing you the premature contraction system. I left this in for you guys to read whenever you feel like it. Okay, so what about here? What do you guys see that's abnormal here? So there is a missing P wave. You're absolutely correct. What else? Idioventricular. Huh. That is a big, big word. Everything is wrong. Yeah. So I can't even tell you if this is it says irregular. I can't even tell you if this is irregular or not. There's just two beats. But yeah, so as you guys can see, the QRS is not just wide, it needs a Zempic. طيب. Well, there's no P wave. and it's very slow, يعني 20 to 40 beats per minute. As a result, what this means is that this is a problem in the ventricles. But this very slow rate does not mean that this is a bradycardia. This is what we will call idioventricular rhythm. Why do we call this idioventricular rhythm? Because when the ventricles are forced to contract, when they become the pacemaker, they are very, very slow. So they're slow and they make the QRS wide. So this is their rate. Their normal rate is 20 to 40. So let's try the next one over here, where it's a lot faster. What do you guys think this is? Okay. Why is this? So you guys are saying this is VTAC, and you're correct, but why? The QRS is wide. It's regular. It's very fast. It's somewhere from 100 to 200, 250. And as you guys can see, very wide QRS going fast. That's it. This is monomorphic ventricular tachycardia. We have another form. We have polymorphic as well. So this over here, is this mono or polymorphic in you guys' opinion? Okay, so this is monomorphic. If it was polymorphic, for example, you'd have a QRS here and then another QRS in another direction. And it might alternate or it might be irregular. There's a lot of different ways that this could happen. Like, what do you guys think this is? So this is ventricular fibrillation. Absolutely. Why is this ventricular fibrillation? As you guys can see, it looks like the word fibrillation. Therefore, it says fibrillation. But the QRSs are wide. There is no narrow QRSs. You can't even tell where anything is in this case. There's nothing identifiable about it, absolutely. And it's not a flat line. So we call this ventricular fibrillation. And this over here is another picture of ventricular fibrillation. This is an emergency. You see fibrillation, you defibrillate. Monkey see, monkey do. I don't know why I have this thing with the monkeys, honestly. Anyways, over here. What's this? Zoom just asked me if I'm playing music. That's crazy. Okay, yeah, so this is asystole. All right, so those are the tachycardias. خلصنا tachycardias. Yeah, you don't defibrillate in this case. This is pulseless electrical activity. Probably pulseless electrical activity. You do not defibrillate. If the patient is alive, you give other measures. If they're dead, Allah yarham. Yeah. Okay. That's it for the tachycardias. خلصنا tachycardias. I hope and they're simple. But now we can go into the bradycardias. Okay. So over here, if the thing, yani, what's abnormal here? What do you guys think is abnormal? Okay, you guys are saying, yeah, first degree AV block, PR interval looking weird. Okay, yeah. So this is a first degree AV block, but how did we come to this conclusion? If you guys see, the PR we said is anywhere from 0.12 to 0.2 seconds, meaning anywhere from 3 small boxes to 5 small boxes, or 3 small boxes to 1 big box. This is bigger than a big box. So we know that there's a problem with the PR interval. The other thing we're going to see is, did a beat drop, yes or no? So if a beat didn't drop, then we're looking at first degree AV block. You just observe these patients. What about this patient over here? Okay, so you guys are saying this is a second degree block, and you guys are saying Mobitz 1. So that is correct. How did we come to that conclusion? Over here, you see the PR is getting wider and wider and wider. And all of a sudden it gets so wide, a beat skips. So this is heart block. This is Mobitz 1. In Mobitz 2, it's a little bit different. The PR interval does not change and a beat drops. طيب. So yeah, progressive prolongation of PR until a QRS drops. Absolutely. Whereas Mobitz 2, the PR is the same. And they also call this Wenkebach. Yeah, over here, this is what you guys were talking about. And the PR didn't change and a beat drops. So this is they consider it classical. This is a lot more dangerous than this type over here. This one, like I said, you might even need to put a pacemaker for these patients. Now, there's a question that I think someone might come up with watching this video later is, okay, let's say I don't recognize this delayed PR. Like this one over here. Let's say this to me looks like normal sinus. I don't think this is like, I don't, this is actually smaller than a big box. So maybe it might be a normal PR. So this might look like normal QRS. What differentiates this over here from a premature contraction? Besides the words tachycardia and bradycardia. So like we said, besides this beat drop, it's otherwise normal. We don't call this a premature atrial beat drop or anything like that. With the premature contractions, what happens is you get the PQRST, sometimes the P, but you get the PQRST, and it's abnormal. It represents some sort of abnormality. So you get everything, but it's abnormal looking. With the beat drops or with the second degree AV blocks, you don't get the QRS, so you don't get the heartbeat. So the heartbeat is skipped. In premature contractions, you get the heartbeat, but it's just weird. That's the difference. So uh, again, maybe I just thought of that, Hein, or maybe someone might come up with it, but in case someone asks. And then what about this one over here? What's going on? Okay, third degree art and P wave marching through. Exactly. So you see these P waves, they exist. They're kind of beating on their own. And the QRS is kind of beating on its own. It's like two people when they're studying, they're both in their own worlds. But in this case, they really shouldn't be. They do not need to be in their own worlds. This is very dangerous. So the atria and ventricles are disassociated, absolutely. Um, and yeah, in physical exam, you might see Canon A waves. Not physical exam, the pressure, the whole A wave, the JVP stuff, whatever. Okay, yeah. As you see, the P waves and the QRS are not associated, so there's AV dissociation. And that's why I say, remember, atria, think of the atria. The P waves, think of the atria. And the QRS, think of the ventricle. The QRS, the ventricles, and the atria, they're not associated. Okay, so now we've done every single arrhythmia that you guys are supposed to cover. So let's practice here. Now, did I do this low quality image on purpose? No, but you might get low quality images on your exam, so I'm doing this as a favor. So you're welcome. So what do you guys think this is? Slow rate, but kind of regular. Online school is crazy. Missing some P wave and some leads. Okay, it's not very clear at all, but this is oh my God, I feel bad for putting this image, but this is sinus bradycardia. If you're to look there are P waves, but the heart rate is just so slow. And if you look at lead two, it's regular, and it's just a huge amount of big boxes. Uh, yeah, no, I'm telling you, like I'm putting this picture on low quality on purpose, but inshallah, look, I'm nice. I get nice images too. What about this one over here? What do you guys think this is? Oh wait, I compressed. That was the evil thing I did. I just realized the evil thing I did here. I compressed it. Okay, no P waves. Yeah. Okay, correct. AFib. Good job. This is atrial fibrillation. Yes, you do, in fact, deserve to say yay. So look, so you look at it looks irregular. Now you're gonna see, okay, it's irregular, probably a tachycardia. Like if you're going to count the rate, like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, that means 66. That means, okay, wait, something's wrong here. Um, you see that the QRSs are occurring at irregular intervals. They're still narrow. You may not see the fibrillation waves, but they kind of do exist. So by looking at this, you'll know that this is atrial fibrillation. This isn't flutter, you would see sawtooth waves. This isn't multifocal atrial tachycardia, you would see P waves. This isn't anything else that might be irregular, because again, there's something that separates them. But this is AFib, and you can exclude it from other compressed photo and clutch. Yeah, I think maybe if I like expanded it, I think maybe the fibrillation would show. Okay, what about this one over here? What do you guys think this is? Atrial flutter, sawtooth. Exactly. The monkey sees, the monkey does. You see sawtooth, atrial flutter. Yeah, good job, guys. Okay, this skip, because it's not relevant to you guys. This over here. What do you guys think this is? Okay, wow, big words. Mobitz 2. Does anyone think this is Mobitz 1? All right. Yeah, so this is Mobitz 1, not Mobitz 2. So look at the PR intervals, not the RR, look at the PR. You see here looks kind of normal. And then it's getting bigger. And it's getting bigger. It's getting huge. All of a sudden, beat gets dropped. So you guys correctly identified that this is a type 2 heart block. However, this is Mobitz 1, as some people pointed out. So good job, guys. So it's progressive prolongation, as one of your colleagues just pointed out. So you see this over here, small, and it gets bigger, it gets bigger, it gets bigger, and then just no beat. Okay. What about this one over here? It is, in fact, AV taking over. Type 3. T-wave is weird. All right. So this is in fact a weird one, if I'm being honest. No P wave, inverted T wave. Okay. No, I'm not gonna throw you guys off and put MI questions here. It does look like end stem, but it's not. Something else. So if you see these P waves right here, there aren't QRSs and P waves that are associated. So this is third degree heart block. So whoever said third degree heart block first was correct. You have random P waves and random QRSs, but it can be so obscure. That's the thing. The reason I'm bringing really obscure images in case they decide to like, make your exam pretty tough. But look, if you zoom in, P, QRS, okay, there's a P, QRS, they're not really related, if you guys see. And it shows even more here, like P, QRS, inverted P, like they're not related to each other whatsoever. So whoever said third degree heart block, good job. Let's try this one. What do you guys think? All right, so this is okay. So this we're done with arrhythmias, by the way, as a whole. Now uh we're at شو اسمه ischemia. Okay, so this is an MI. Good. Is it a STEMI? And STEMI, what vessels involved? So someone said a vessel, which is correct. So lat MI. So yeah. So this would be an anterior STEMI. How? V2, V3, V4. But we will know this inshallah uh, right now. So do you guys understand everything from the arrhythmias? Well, is there anything that's not clear? That was like the bulkiest part, by the way. It gets way easier afterwards. Clear like glass, mashallah. Like, do you guys want to take a break or continue? طيب, let's take 5 minutes for Aisha. Does that work? طيب, خلينا, yeah, let's do that. Let's take a 5 minute break for Aisha and then let's come back at 8:37. Does that work? Okay, I just want to clarify. First of all, welcome back, everyone. I want to clarify one thing about Wolff Parkinson White. So, first thing with SVT, there's three pathophysiologies that can cause supraventricular tachycardia. في ال AVNRT, so AVN, which is the most common, ال AVRT, and ATAC. طيب. And it's just AT. Okay. So usually when we talk about SVT as in junctional, like supraventricular tachycardia, the stage right after junctional tachycardia, the most common pathophysiology of this is AVNRT. Wolff Parkinson White is a type of SVT that's caused by the AVRT pathway. Now, with when we talk about AVRT في الأورثودروميك والفي الأنتيدروميك. طيب, orthodromic narrow QRS, antidromic not narrow QRS. Well, most of the time, Wolff Parkinson White will be orthodromic, meaning the QRS doesn't necessarily need to be wide. For what identifying feature can you find? The delta wave. So basically, imagine you're looking at the QRS. So this is a normal QRS. Instead, it has like an indentation. طيب. Even if it's narrow, this indentation right here is a delta wave. طيب. For those of you who asked. Thank you guys. Let's go into MI. Okay. Let's start off by talking about how how the changes happen with ischemia. So in ischemia, that's bad. Heart cells are dying. So as a result, the QRS will reflect that and the ECG. Now, we also will talk about STEMI and STEMI, difference between an ST elevation related to a myocardial infarction versus one that isn't, and then how do we localize ischemia? This is literally, if you're going to walk out with anything, it's this. And then when do we do extra steps? Over here are a bunch of different pictures, which are almost showing you the same thing. So first of all, over here, we have an ST and non-STEMI or non-ST. ST elevation means the entire wall of the myocardium is involved. So this is a transmural infarction. So as a result, you'll get this ST elevation because the entire wall is affected, right? A non-ST elevation, this is usually subendocardial, meaning not the entire layer, but a part of it. And as a result, it will go into an ST depression. طيب. Over here, we have the different changes over time. This, again, look at it. Would I say it's important? The deep Q waves part is pretty important. That's probably the takeaway, is that you can identify old myocardial infarctions or old heart attacks from deep Q waves. So yeah. Over here, this is don't rely on this too much, but this is just showing you the difference between STEMI and non-ST elevation or STEMI and ST elevation MI and non-MI ST elevation. So not STEMI and STEMI, ST elevations related to heart attacks and ST elevations that aren't. So this right here, this concave ST elevation, this is related to something that's not myocardial infarction, like benign early repolarization, like pericarditis. However, this point right here, where it's convex, this is related to ischemia. طيب. How do you decide if it's concave or convex? You can draw a line between the J point and the apex. Now, the J point's important because this defines what an ST elevation really is. So the J point, you basically compare it to the PR segment. And if it's over 1 millimeter tall, this means that it's an ST elevation. So the ST segment is elevated over here. The J point is elevated, therefore the ST is elevated. And as a result, this could be an MI or not an MI, depending on what we're looking at. So yeah, it could be pericarditis. Okay, read. If you are in third year, you should know how to read. This I don't want you guys to read. This I want to explain actually. But anyways, here if we're gonna look at the heart, let's start off with this over here. So as you guys see, like I said, the different leads represent different parts of the heart. And I said, like, for example, we talked about it earlier, so let's just recap over here. We said in 1, AVL, V5, V6 is the lateral surface, which is mostly supplied by the circumflex artery. V1, 2, 3, and 4, the anterior and septal areas, are usually represented by the left anterior descending artery. And then the inferior surface, 2, 3, AVF, is represented by the right coronary artery. Now, the right coronary artery also supplies the posterior heart. So as a result, if we have an ST elevation in 2, 3, and AVF, our assessment is not complete until we also do posterior leads, which is important because it helps us assess, complications and things like that. So right here, it's written for you. Septal is V1, V2, tear is V3, V4, lateral is V5, V6. You have anterior septal, anterior lateral, extensive anterior, which is the entire precordium. And then, yeah, one thing to note are the reciprocal changes. That's another thing that's pretty cool, is that sometimes if you see ST elevations in one place, look for ST depressions in the other place because it reciprocates. So if you see, for example, that you have an inferior MI, so 2, 3, and AVF, and then these have the ST elevation, you might be able to see an ST depression in 1 and AVL. So this is just an example of the reciprocal changes, and you have this table over here. One thing very important to note, if V1 is the only ST elevation, is this considered a myocardial infarction? Yes or no? Why not? Needs to be 2 or more consecutive leads. Okay, so what if I said AVL and V2? They had a significant ST elevation. Is this a STEMI? What do you guys think? So V2 and AVL. If there is an ST elevation in V2 and AVL, it's also not, because again, these aren't consecutive leads. So consecutive leads means V1 to V4, V5, V6, 1 in AVL, 2, 3 AVF. These are consecutive leads, right? So remember that. Now, someone might ask, okay, what about AVR? What about it? This is theoretical. It's usually never elevated. If it is, you might have a problem. But because it means that the entire system is like not being supplied. But again, it's not very common. It's actually very rare. Okay, practice time. So, people say, yeah, people say it's LCA, but if the patient is still alive and they have that big of an infarct, I think that alone is like a medical miracle. Okay, so you have a 68-year-old woman with chest pain, and then you have this ECG. So, what do you guys think? So someone said it's B, 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 B. Okay, you're right. It is B. Anterior lateral wall myocardial infarction, probably recent. How did we come to this conclusion for the viewers on YouTube? So V1, if I was to look at it, okay, yeah, there is an ST elevation. The J point is pretty high. V2, yes, J point's over here. V3, yes. Okay, so I know it's definitely anterior and septal. Um, V4, V5, V6, yes, they are elevated. One is elevated, AVL is elevated. So this is anterior, and this is anterior wall, myocardial infarction, and it also involves the lateral wall as well, somewhat. This is mostly anterior. But in you guys' opinion, um, 2 and 2, 3 in AV. Do you mean V2, V3, or actually one in AVL? Oh, okay. Yeah, just making sure. Okay, so we see these ST elevations over there. All right. So what artery do you guys think is involved here? LAD. Yeah, most likely LAD. Why not left circumflex? Left circumflex would not cause V1, V2, V3, and V4 elevation. Um, yeah, it wouldn't really affect anterior. Left anterior descending supplies left circumflex, by the way, which is why you can have lateral wall involvement. Okay, what about this ECG over here? What do you guys see? Okay. You guys see Q waves. Yeah, left circumflex is a branch of the left anterior descending. But usually when we talk about left anterior descending, sorry, left circumflex is a branch of the left coronary, which is related to the left anterior descending. And then there's a diagonal branch from the left anterior descending that can help supply the left circumflex area. So excuse that. Okay, so you guys say one, AVL, V5, V6, anterolateral, V2, V4. Okay, so yeah, just look at one. So this is V2. Okay, it's elevated. V3 is elevated. V4 is elevated. V5 is elevated. V6 is elevated. And then here, one, AVL is elevated. So this is definitely anterolateral. Where is it? Yeah, it's anterolateral. Yeah. Okay. And if you guys notice, for example, in 2, 3, and AVF, because this is the same thing, 2, 3, and AVF, you see the reciprocal depressions that I was talking about earlier. There are no deep Q waves. Yeah, deep Q waves, Yani, if they come up, I'll show them to you.
Okay,
Okay.
so the thing is like what I think she's confused about, or what confused me also, can you go back to the previous slide? The V3, that's why we got confused. Like the Q waves looks a little bit down, Sami. That's
Yeah. The Q wave is this. This is the Q wave.
ah, okay. That's what يعني
Yeah.
confused.
No,
Mhm.
no, it's very valid. Don't worry. This yeah. V2, V3, V4. We've mentioned that. Okay. What about this ECG over here? What do you guys see here? Okay. So you guys are saying C. Why are you guys saying C? 2, 3, and AVF. Absolutely. And you can see the reciprocal changes in V1 and V2 as well. Um, Now, because of that, my question to you is, can we khalas, say this is just an inferior MI, or should we do something else?
I think posterior also, because posterior is supplied by the same artery.
Please stick with the
Correct?
chat. Yes. So, but you are right. We do need to do the posterior leads. So the V7, V8, V9, the posterior leads are very important to do. And this is kind of showing you that it could be just inferior wall or it could be right ventricular MI. And the thing is, with a right ventricular MI, you do have to be very careful because if you give this patient nitroglycerin, they will collapse. And nitroglycerin is a pain medication that they give for heart attack patients, except for these heart attack patients. So yeah, ECG is pretty cool. Okay, what about this patient over here? What do you guys think is going on? Okay, so someone said something. Early repolarization. Why is this your conclusion? Why do you think this is an early repolarization? Okay, so let's take a look, right? Let's say we're gonna stick with the logic that we got. Are there ST elevations in multiple leads? Yes, there's V3, V2, V3, V4, and I believe no, this is an elevated, this is an elevated. Let's see this one. This one you could say it's elevated. Okay, so there's multiple leads involved. Um, you won't really see it over here, but if you looked at this, for example, remember the whole convex concave. So this is concave. And this is an indication that you might have a benign early repolarization, like you see here. And otherwise, the QRSs look pretty normal. Like the whole thing looks normal with the exception of this ST elevation. So if you looked at this, you might think, oh wait, this guy's having a STEMI. But if you look at the J point, yeah, there's the notch over here as well. This notch right here, and it's concave. Now, had the idea with the whole concave convex is this is safe. Oh, it's not gonna let me more. Okay, you know what? Is that yeah, this is an early repolarization. So this is safe, but if it looked like this, it would be dangerous. That's the point. Should you still be worried about an MI? Yes. But Annie, there's another lecture that'll explain when you should think and not think MI. Okay. What about this over here? What do you guys see? Diffuse ST elevations, probably pericarditis. Exactly. So this is pericarditis. So with pericarditis on an ECG, you're looking for two things. You're looking for ST elevations and you're looking for PR depression. Played. So as you guys, let's take an example of, let's look at this one right here. Let's look at lead two. Yeah. As you guys can see, the ST segment is elevated. And if you guys notice, the PR is depressed. How do I know this? This is supposedly the isoelectric line, which means or this is like the point where it's neutral. And then the PR is just lower than that. It keeps going. It's kind of slanted and it's going down. So that's how I know that there's PR depression. And then there's also ST elevation. And the thing is, it's not just one lead. All leads have this, making pericarditis more likely. And it's concave. Peri the platypus, exactly. Peri the carditis. Uh, so me and myself like a few years ago. Okay, so yeah, this is pericarditis. All right. 60-year-old man with chest pain and elevated troponin T. What are you guys thinking? Okay, so someone said it could be a posterior MI or it could be an end STEMI. But let's can I do? I think I could. Oops, did something by accident. Just gonna try send a poll, but so there's an inversion in V. Okay, so we agree that V1, 2, and 3 have T-wave inversions, and V4. All right, they have T-wave inversions, which means we should look at 2, 3, and AVF because this might be reciprocal changes of an MI. Do you guys see an ST elevation in 2, 3, and or AVF? No, there isn't. So they're fine. The right coronary is all good, but the left anterior descending, not so much. So this is, in fact, so yeah, the ST segment is depressed because look, this is the PR segment over here, and the J point is lower than the PR. So this is an ST depression, and there's T wave inversion. So this is an indication that we have an end STEMI. So V2 to 4, 1 and AVL also have the same change, but I focused on V2, 3, and 4 because they're more prominent. So yeah, good job, guys. You're doing amazing. Okay, what about this one over here? And decreased LOC means decreased level of consciousness, by the way. Anterolateral MI. Very big words. You could be correct though. Lad infarct. Also a big word. You could be correct though. Yeah. So if okay, only anterior. That's a big claim. Okay. Let's look at this. So we said it's probably anterior. So already you can see a very prominent ST elevation in V2 and V3 and V4. V5 has an ST elevation. V6, yeah, not really. Okay, let's say it's not V6. 1 has an ST elevation. AVL has an ST elevation. And remember, ST elevation is one small box, so 1 millimeter. V1 also has an ST elevation. So like just to show you guys, this, it's not gonna let me do it. But this, so we have the 5 big boxes, or we have the big box which has 5, and let's say this is a 1 by 1 box. So if the P is here and the ST is here, this is the J point, or the J point is here, and the PR is at this level. This 1 millimeter for almost all of the leads is enough to say this is an ST elevation. For V2 and V3, there's like 1.5, 2.5. Again, very, very nitpicky. Don't focus on it too much. Okay. Diabetes complaining of chest pain. What do you guys think? Anterior MI. Absolutely. How did we come to this conclusion? Let's look at V2, ST elevation. V3, ST elevation. V1, not really. V4, ST elevation. V5, ST elevation. V6, not really. 1, not really. And then AVL, kind of. So we can definitely for sure say that this is an anterior MI. What about this patient over here with chest pain? 5 is affected without V6. Exactly. It needs to be contiguous or consecutive. This is inferior what? Yeah, so this is inferior. How did we know that this is an inferior STEMI? So 2, 3 AVF have ST elevations. We can look for reciprocal changes. There is a reciprocal depression in V1 and V2, as well as V3, but not V4. So this is an inferior STEMI. And of course, our evaluation is not complete. We will need to do a posterior. So yeah, this is telling you already. Now this is inferior and posterior. Um, there is like a trick that some people do where if you were to flip this page upside down, V1, V2, and V3, as well as V4, would look like ST elevations upside down. So this is an indication that you can do that this is a posterior MI as well as an inferior. But V6, V7, V8, and V9 are important to have too. Okay. Over here, what do you guys think is going on? Q waves. Yes, this is an old MI. Exactly. So V1, V2, V3, as well as kind of V4, have these deep Q waves. And these deep Q waves are indications that there was an MI, but it's old. Q waves, يا طوال العمر. Q, 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 Q. So these are the Q waves right here. And they're very deep. So this is an old MI. Now, there's a reason why this is very high yield to know is that with diabetics, their presentation of MI can be a little bit different, where they may just complain of just shortness of breath, or they may not even know that they had a STEMI. So that's why it's very high yield to identify it. But yeah, they do look like inverted R waves, but that's why you gotta like take a close look And I know there is zoom on an exemplify, so you should be able to do that too. But see, PQRS over here. So that's the Q wave. So trust me on that. Okay, what about this one over here? Where is RS? So this is the Q. This has to be the R, and the S is kind of buried. The S and T are buried. Um, Again, kind of obscure, but this is what happens with the ECG in this MI. And this is probably a big MI. How would I know? They'll usually give you the case that this is, for example, someone like they probably will tell you that this is diabetic hypertensive. If you see these deep Q, did it skip slides? Yes, that's yeah. If you do see these deep Q waves, this deep Q over here, this should make you think old MI. If you see this picture over here, old MI. That's what you should think. Diabetes and hypertension can be a buzzword for old MI. Because again, they're silent and they may not tell you, and they may tell you that they're not complaining of anything and they're fine, or they're coming in for a checkup and you decide to do an ECG and you saw these. But if you see these deep Q waves, this alone is enough to make you think of an old MI. طبعا it's not any you don't just diagnose by an ECG alone. You need other investigations as well. You have to do enzymes, full history. You have to try find what any indication that there was something that went wrong. Yeah. So here it's kind of similar. So they're telling you here, rather than being an anterior old MI, they're telling you it's an inferior MI. How did they come to this conclusion? If you look at 3, this is a Q wave and it's considered deep in this case. So again, it's unfortunate, but you do have to be a little bit nitpicky. Why not V1, for example? If you look at V1, this is the P, this is the Q is kind of buried, and it's R, S, and T, right? So this depression isn't Q, this is S. And this elevation over here is R. Uh, Again, I know it looks wrong, but you kind of just have to adapt to it. But like, let me show you, Hein. Um, okay, so if you see, this is the P, the Q is buried, and that small elevation is the R. S, T, P, Q, R, S, T. Yeah. No, even AVF, the Q wave doesn't look that deep. But again, keep in mind, it's not an acute STEMI. With an acute STEMI, you do need 2 leads. With an old one, there's certain criteria. But if you see one deep Q wave, that is a sign that this is an old STEMI. Again, they don't really ask old STEMI questions because it's not of any. It's not that much. But again, because it was part of your lectures, I am including it. That's the only reason why I left it aslan. Let's try this one. I think this one will be a little bit easier. ان شاء الله بس ما نسينا how to solve STEMI. Okay, there's ST depression in so many leads and STEMI. Yeah, so this is an STEMI. So yeah, multiple ST depressions. There's no ST elevations. These aren't reciprocal changes of anything. So this is an STEMI. So good job, guys. Yeah, we know it. Yeah, exactly. The elevated enzymes. If the enzymes were normal, we would not call this an STEMI. We would call this what? Not many of you guys brought that up. Unstable enzyme. Exactly. Good job. You guys are very smart, mashallah. What about this? Let's see. What do you guys think? All right, so this is an early repolarization, similar to the one we saw before. Yeah. And remember, look at this notch right here. This is telling you early repolarization. Because remember, the ST segment usually represents ventricular repolarization. So this is telling you that there was an early repolarization. So that's another way of thinking about it. Concave notch, exactly. Okay, we are done with the ischemia. Uh, so here's some practice. So let's try out some practice. Let's see. Okay, if you're gonna say STEMI, tell me where. V2 and V3 are low-key looking kind of weird. Let's look at V2 and V3. You are right, they do look weird. They're not elevated, but they look weird. So yeah, exactly. The J point is on the same face the baseline. So V2 and V3, if this was a STEMI, V2 and V3 aren't part of it. Is there anywhere else that you guys might, anything else you guys are thinking of? Strain pattern. Okay, we're not gonna do strain pattern. Strain pattern would be with the QRS complexes. You thought it was n-STEMI. You are right, it is n-STEMI. So yeah, you see ST depressions, you see T wave inversions, and you don't see any ST elevations. We tell you, and that they have high enzymes, you have an n-STEMI. Again, making them. Wait, what the heck happened? Why is it moving like that? That's so weird. Oh, that's why. Never mind. Okay. I don't know what Zoom's cooking. How about we do this one? Let's see. Oh, من الحين this is a STEMI. Oh, you guys already said that. Never mind. I didn't mean to say anything. Nice. This is an inferior STEMI, and you see some reciprocal changes over here. Is your assessment done? And posterior possibly. So we need to do a 15 lead ECG, which involves the posterior leads. Good job. What about this one? I'm sign pericarditis. Okay, so we're done with ischemia. This is related to atrial ventricular changes. So we're done with ischemia. Um, left atrial enlargement. Good job. Okay. So ischemia. Is there anything you guys don't understand? Off one lead is insane. Mega that would be insane. Clear like Minecraft glass. Minecraft glass is not clear. We have one more lecture and then we're done. Guys, can you please stop like having going to war in the chat? I want to know if you guys understood everything or not. Okay, okay, you guys can fight. Do you guys want a break? I don't mind. What do you guys think? طيب خلاص, let's take 10-minute break. Sure, yeah. We won't take long with this portion anyways. Let's do 10 minutes. We'll come back here at 9:25. Sound good? Okay, welcome back. Yalla, we're gonna finish this very quickly. So let's get done. Let's talk about the chambers. So as you guys should know, as third year medical students, you have four chambers in the heart. So you have the atria, two of them, and you have two ventricles. So with this in mind, they can get bigger, and that can be a problem because that can lead to heart failure. So if something is bigger than it's supposed to be, bad. Okay. Now the left side of the heart, the left atria and left ventricle, the atria enlarges, the ventricle undergoes hypertrophy, by the way. Nitpicky names, but bear with me for a moment. Usually it's related to cardiac causes, so things that have some relation to the heart. So aortic and mitral valve pathologies, hypertrophic cardiomyopathy, and hypertension can all cause left atrial enlargement and therefore left ventricular hypertrophy, and vice versa. Right atrial enlargement and right ventricular hypertrophy, keep in mind they have a direct connection to the arterial lung system. So the pulmonary artery, for example. So as a result, things that affect the lungs can affect the right ventricle and therefore atria. So uh, so cyanotic heart disease, that's what I mean by CHD, chronic obstructive pulmonary disease, which you guys should know for your exam, pulmonary hypertension, embolism, and mitral valve pathologies can also relate to the right atrium and ventricle hypertrophy. So with the atria, like we said, if you go back to the monkey see and then the monkey doing, the atria is related to the P wave. So if you think there's a problem with the atria in terms of size, we're going to look at the P wave. And then with the ventricles, we said they're related to the QRS. So when the monkey sees QRS abnormalities, the monkey knows that, okay, this is related to the ventricles. Now, you do have to do basic addition because sometimes it does look like an MI. So there are some formulas, which is just like X plus Y, but yeah. And then that's why we have to check the entire ECG because a lot of things can happen. Like if you have left atrial enlargement, you can also have left ventricular hypertrophy. They're not isolated things. They can all happen together. Let's talk about the P wave. Like I said, the monkey sees the P wave, the monkey knows, and now this is related to the atria. طيب. So this table right here, I want you to take a good look at this table over here. We're looking at two leads, lead 2 and lead V1. Lead 2 and V1. Normally, the P wave in lead 2 looks like a normal P wave. And the P wave in V1, well, it doesn't look like how you imagine a P wave should be, but this is the normal of V1. If the right atria is enlarged, that means just a moment. Lead 2 will look like this, and V1 will look like this over here. So it will form a peak and then a scoop. So a peak and a scoop, right? So if you see a peak and a scoop in V1, that's a sign that you have right atrial enlargement. Plus, you see this this kind of mountain with this parabola over here. With left atrial enlargement, think of a camp, right? And I could draw like, if you know the Nog logo, the camel milk company, it looks like a camel, right? And a Bactrian camel. The specific camel I'm talking about is a Bactrian camel, one with two humps. It's also called an Asian camel. The African camel has one hump. Anyways, back to medicine. With V1, the left atrial enlargement, it looks pretty much the same, in V1. So with V1 in right atrial enlargement, peak and scoop. In left atrial enlargement, it's normal. In 2, this mountain-looking structure, and then the cam, and for right atrial enlargement, and then the camel for left atrial enlargement. What about right and left atrial enlargement? Well, with 2, so if you look at lead 2, you will still have the camel, so it means you have a part of left atrial enlargement. And with V1, you'll have a big scoop and dip, which relates to the right atrium. So again, they can happen together. And they happen together in some pathologies like restrictive cardiomyopathy. Fun fact. Okay. That's the appearance. That's the monkey sees these, the monkey does these. And I would recommend if you took a picture of them or you screenshotted them, they would really help you. Why does this exist? Why don't we just have normal looking P waves? Well, the P wave is actually two P waves. funny enough. And the P wave that we see is the net result of these two P waves. So because the atria don't contract independently, they contract together, they give you this one unified structure, even though physiologically, due to very small differences, they don't 100% do that. So in a P wave, you're looking for it to be 2.5 by 2.5 millimeters, which means 2.5 to 2.5 small boxes. Okay, yeah, so exactly, I'll get to that. So going back to this, in the normal P wave in lead 2 should be 2.5 by 2.5. The second it's not 2.5 by 2.5, you have a problem. So whether it's taller or wider, there's a problem. So back to your point about three boxes in length, so 3 millimeters. As you can see in left atrial enlargement, this is going to be bigger than 3 millimeters. And with right atrial enlargement, it will be taller than 2.5 millimeters. So this will be big, this will be wider than 2.5, this will be taller than 2.5. And that's when we're talking about lead 2. So it could be 3 big boxes, it could be 5 big boxes. I mean, five big boxes would be crazy. Anyways, so yeah, memorize this if you can. Just remember, right atrial enlargement, mountain, and peak and dip. Left atrial enlargement, camel, looks normal. Right and left, camel, scoop and dip, peak and dip. Okay, what about the ventricles? So the ventricles, like we said, pulmonary for right, cardiac for left. Now, what are the mandatory criteria for right ventricular hypertrophy? The R wave must be greater than the S wave, or the R wave in V1 must be greater than 7 millimeters without right bundle branch block. What does right bundle branch block look like? Ma'alaikum. Don't worry about it, not part of your curriculum. Supportive criteria include right atrial, right axis deviation, T wave inversion in V1, S waves in V5 and V6. With left ventricular hypertrophy, the mandatory criteria is that you need to see an S in V1 plus the R in V5 and V6 being greater than 35 millimeters. If the patient is younger than 35 years old, it must be 50 millimeters. Because the hearts can get bigger because younger people tend to be more athletic, etc. Supportive criteria: left atrial enlargement, left axis deviation, and ST changes, whether it be depression or elevation or whatnot. So let's recap. RVH, V1, R wave greater than 7, or R is greater than S wave. With left ventricular, S in V1 plus R in V5 and V6 is greater than 35, or if it's a patient younger than 35 years, 50 millimeters. That is the basic concepts for enlargements. So let's start. Over here, they're already telling you there's some sort of abnormality in the P wave. So what is the abnormality? So when we're looking at enlargement hypertrophy, for enlargement, look at for the ventricles, look at V1, V5, and V6. For the atria, look at 2 and V1. Okay, so you guys saw the camel in AVF, exactly. Camel in AVF. So yeah, 2 in AVF, and then V1, V2, V3, V4, V5, and 6. So these two for the atria, and these 6 for the ventricles. So as you guys see, there's a camel over here. طيب. And there's also a camel in 2. So that means we look at, and this for us is enough. And Hain, we know in we have the camel. Camel means, yeah. So for the atria, just to go back, just so we have this over here, V1 and 2. طيب. 2 and AVF might look the same, as you guys can see here. And V1 is important for everything. And then for the atria, V1, V2. For the ventricles, precordial. So yeah, we see the camel over here. Oops. So now we're looking at V1. Now V1, we're looking at the P wave. So again, does the P wave look abnormal to you guys? It looks normal, exactly. So normal looking V1 and a camel in 2, which means we have what? Sorry, normal in V1 and camel in limb lead 2. Left atrial enlargements. Exactly. Now, what about here? What do you guys see? Tall P waves in lead 2. Yes, the P wave is tall, bigger than 3, bigger than 2.5 small boxes. Now we look at V1. Do you guys notice anything about V1? Okay, V1, it does look somewhat normal, but if you take a closer look, you see it's not, again, online school vibes, but it's a peak and a scoop. But as long as you see this in in limb lead 2, this is an indication, and you have what condition? Right atrial enlargement. Like someone said, right ventricular hypertrophy. Right ventricular hypertrophy, like we said, and you have to look at V1, and you have to see, for example, is the R wave greater than the S wave, or is the R wave greater than 7 millimeters? Here, the R wave is not that great, actually. The R wave is down. The Q is buried over here. So it's a negative R wave. So it doesn't really go with right ventricular hypertrophy, but actually, you should think more of left ventricular hypertrophy, but it's not that case if we do the math. What about this patient over here? Inverted camel. No, it's still a normal camel. Okay. So we see the camel in limb lead 2. So let's look at 1. All right. Let's try find a normal P wave in V1. Please give me a normal one. Yeah, this is barely discernible. Okay, that's the Q. Okay. So yeah, if you look at this right here. So here they're trying to point out, I know it looks weird. Here they're trying to point out the peak and scoop. So this is LAE and RAE. Let me explain. So let me go back to the table, because the table is the only thing that's going to make a lot of sense. So remember, the camel can be in left atrial enlargement or left atrial enlargement with right atrial enlargement. So if the V1 looks normal, left atrial enlargement. If the V1 looks like the one for right atrial enlargement, then it's left atrial enlargement with right atrial enlargement. So this is what they're trying to show. And it looks really weird. So here they're trying to ask you guys. And then this is by atrial enlargement. So let's go back, see how does this make sense? The camel, do we agree that we see the camel? We see the camel over here, صح? Okay, good. And it's a Bactrian camel. But then this over here, they're trying to highlight the peak, the peak and the scoop. Peak and scoop. So this is a sign of right atrial enlargement. Yeah, just in lead 2. So this over here is the peak and the scoop that we can see in right atrial enlargements. I understand it looks really weird, but if you compare it, for example, to this over here, the P wave here looks very normal. But the P wave and the other one, and this one over here, doesn't look that way. But can you guys appreciate that difference? I get it. It's very small. We really have to look, but that's what it is. The rule of thumb, or the advice I would give here is, when you see a camel, look for the mountain on V1 or V2. If it's not clear, I'll repeat. I don't mind. Okay, all good. Alhamdulillah. Like, let's look over here. So what do you guys see that's abnormal here? Okay, you think it's LVH because of tall R waves. So let's see. There are very tall R waves, but if you, anyway, let's see the math. Over here, we have a V1 that is over 15 millimeters tall. And then V2 is tall, V3 is tall. If we look at V5 and V6, they're not as tall. So this is right ventricular hypertrophy, not left. How do I know that this is right or left? So we said for right ventricular hypertrophy, you look at V1. You're looking for one of two things. The R wave is greater than the S wave, or the R wave is taller than 7 millimeters without right bundle branch block. And I said, don't worry about right bundle branch block because it's not going to show up. But here you can see that this is a very tall, it's bigger than two big boxes, so it's over 10 millimeters hetta. As a result, this would be right ventricular hypertrophy. If you look at V5 and V6, so remember, let me go back to that slide just so we have the math. قدامنا. So again, R greater than S or R in V1 greater than 7 millimeters. With LVH, the S of V1 plus the R in V5 and V6 has to be greater than 35 or 50 if the patient is under 35. So if you're going to do the math for the S wave, so this, let's say this is around, it's not very clear, but let's say this is around 10 millimeters. Um, Over here, they didn't specify the age, so maybe it could be by any double hypertrophy, but the main abnormality here is right ventricular hypertrophy. But what about here? Keep in mind, for the sake of exams, it's going to be very prominent. The hypertrophy will be very prominent whether it's right or left. Yeah, so this would be left ventricular hypertrophy. So you know it's not right ventricular hypertrophy. Why? The R wave barely, right, in V1. The S wave is pretty big. This is a huge S wave, right? This S wave alone is تقريبا this is the S wave over here. It's around 15 plus the R of V5 and V6. You're definitely looking at something over maybe even, I would say this is maybe even around 50 millimeters. If I had to the patient was young, you could say that this is left ventricular hypertrophy. But here, alhamdulillah, the math is done for us. So it's V5 or V6, by the way, not V5 and V6. So yeah, 38. Over here, what do you guys see? Okay, why do we say that this is left ventricular hypertrophy? Okay, so let me explain. First of all, uh, yeah, oh wait, it's all done for me. Alhamdulillah. I love it when that happens. So these alone are 35 millimeters. Like the S wave is alone 35 millimeters. This had to, if I was going to do the math or V6 and V5, which are already very tall, uh, I mean, they're already huge. So yeah, so V4 to V6, yeah. Just mainly look for V5 and V6, the R wave of V5 or V6, and then the S wave of V1. What about this over here? What do you guys think is going on? Okay, anterior MI with LVH. Interesting. Okay, so you are right about the LVH part, but the anterior MI. Now, I understand why you said anterior MI, but if you were to look at, let's say, I think this one might be a little bit more clear. The S point, or sorry, the J point is had to less than a millimeter. It's right around here. It's less than 1 millimeter, right? Um, or head to here, it's buried. It's not very clear, but it's less than 1 millimeter. But you see the hypertrophy, right? The thing is, that's one of the reasons why it's very important to identify uh, the just a moment, left ventricular hypertrophy and the right ventricular hypertrophy because they do look like they could be MIs, but they're not. Or if you were to like spread this out a little bit more, you would be able to discern where the J point is, and it would be a lot more clear. If, yeah, when you see this, think hypertrophy. You're right. And again, suspecting it's an MI, depending on system in symptoms in the hospital, never a bad idea. Because it's better safe than sorry. But again, for the sake of your exams, this is left ventricular hypertrophy, but I can understand why you would think it could be anterior STEMI. What about this one over here? What do you guys think? Okay, left ventricular hypertrophy. Yeah. So this is also left ventricular hypertrophy. It'd be funny if this wasn't left ventricular hypertrophy. So what do you guys think? Oh, wow. Okay, yeah. So there is left ventricular hypertrophy, but there's also left atrial enlargement. All right. And there's left axis deviation. It's again another thing that's important to identify. How did we confirm that this is left anterior, left atrial enlargement? The camel. And then if we look at V1, uh, if we can discern a P wave, uh, there's not really a discernible P wave, but again, the assumption here is that it's normal. Ooh, like the P waves are barely discernible. Let me look at V2. Yeah, no, V2, there, you have that signature S. Like it's still the normal the normal P wave. Again, that's fine. Uh, yeah, so left ventricular hypertrophy with left axis deviation and left atrial enlargement. What about this one over here? Okay, right ventricular hypertrophy. Cool. You guys are right. And right axis deviation. Yes, there is right axis deviation. And scooping. Huh, what does the scooping mean? Right atrial enlargement. So yeah, axis deviation, right ventricular hypertrophy. The scooping, I see the scooping, but they don't. Let's do the math. Yeah, this is 2.5 tall, and then there is a peak and scoop, but the P wave into looks normal. But again, it's good that you look for it. All right. عشان ما تزعلوا. What do you guys see? Oops. Spoiled it by accident. Oopsies. Okay, well, you guys saw it. LVH and camel. Yeah. LVH and camel, so left atrial enlargement and LVH. What about this one? All right, so there is left ventricular hypertrophy. Is there anything else? There is right atrial enlargement. Yeah. But let's look at lead two. Okay, so this is technically by atrial enlargement. So ONN, you guys did a good job and you identified peak and scoop that we could see in V1 and V2. And then again, it's wider than three. Wait, the wrong one. It's wider than three. It's wider than 2.5, and it's taller than 2.5. So there should be a camel, but again, the camel makes it easier, but the whole point of the camel is to tell you that it's wider than 2.5 small boxes.
Wait, didn't we say the camel is for left arterial hyper? I'm kind of mixing up.
Okay. So
That's
camel, left atrial.
uh
All right. This, if we're going to, for example, let's say camels don't exist. Let's say we don't have camels anymore. The whole point of the camel is to show you in that it's 2.5 millimeters or wider is enlargement of the left atrium, and 2.5 millimeters and taller is enlargement of the right atrium in lead two. That's
so
effectively the whole point.
so enlargement and like 2.5 sh- tallness width is right. If there is a
No,
bike,
2.5 height and taller is right.
uh,
2.5 width and wider is left in
okay,
lead two.
yes.
Okay. See? All right. Then we have some practice, so let's try these out. What do you guys think? Yeah, so this is right atrial enlargement. No, this isn't left because it's smaller than 2.5. But again, it's hard to discern. What about this one? Left ventricular hypertrophy, absolutely. How do we come to that conclusion? Look at the R waves here and the S wave here. All right. So some other facts that you guys might come across in terms of ECGs, the U wave, going back to it. So with repolarization, if the U wave only exists to represent delayed or inappropriate repolarization, and this happens in hypokalemia or low potassium. Electric alternans, this is a sign you'll see in cardiac tamponade. If you see the QRSs, they alternate in height, and this is a sign that you see for cardiac tamponade. Here is my super summary of the most important things I think you should focus on. Again, with the monkey see, monkey do aspect. يعطيكم ألف عافية. I hope you guys benefited, inshallah. And please do give me feedback. There is a quiz. You could use it as practice, but I know it's a lot of information. I hope I made it simple. Feel free to reach out to me anytime. Just before I conclude, is there anything you guys want me to re-explain? Anything you guys don't understand? All right. يعطيكم العافية وتصبحون على خير. I wish you the best of luck on your exams. I really hope that you guys found some benefit.